So guys, let's now talk about the elbow joint. Well, elbow joint is a type of a synovial joint again, and the sub-variety of the synovial joint is a hinge. So the type of elbow joint, it's a hinge joint, and it comes under the synovial variety. Well, we know that hinge joint are those which only allows the flexion and extension. Like quite a few example of hinge joint in the body. Interphalangeal joints are the hinge. The elbow joint is a hinge. And when I say elbow joint, I'm mainly talking about the humerus and the ulna. So it's humero-ulnar joint. The radius is not participating in the joint of in the elbow joint. We talk about the radius in the elbow joint complex, where we also consider the superior radial-ulnar joint together because they all share the same synovial lining. So as I was talking about some examples of hinge joint, we have interphalangeal, the elbow joint is a hinge joint, ankle is a hinge joint. Few says that even the knee joint is a modified hinge joint, or it is considered as a condylar. Now first in the elbow joint, let's look at the lower end of the humerus and upper end of the radius and ulna to understand that how exactly synovial lining is encircling it. So here is a picture in which you can see the lower end of the humerus there with the radius and ulna. That's an anterior view, and this here is the posterior view. The capsular attachment, obviously inside will be the synovial lining. The capsular attachment is in such a way that the epicondyles are left outside. So you will see this is a capsule here which is running above the fossa over the capitulum and trochlea. So guys, if this here is the attachment of the capsule, what you can see is that what are the things which are inside the capsule, which comes inside the capsule are the two fossa that you see from the front. Now this here is what? That is capitulum, and this is trochlea. You can see capitulum and trochlea. Above the capitulum, the fossa is called as the radial fossa. And above the trochlea, the fossa is the coronoid fossa. That's the coronoid fossa. So the point is, when during the flexion of the elbow, this head of the radius and the coronoid process of the ulna, they need a space to go in, then only the complete flexion of the elbow can take place. Imagine if there is no fossa above the capitulum and trochlea, so the elbow flexion would never complete because the coronoid process in the head of the radius will get stuck to the lower end of the humerus. And that's why these fossa, they accommodate the radial head and the coronoid process of the ulna, and that's how the elbow flexion is completed. So these fossa are very much required. Similarly, we need a fossa on the posterior side of the humerus, and that is, we all know that is called as olecranon fossa, to accommodate the olecranon process of the ulna in extension. So this here is the olecranon process, and of course this fossa here is the olecranon fossa. So even posteriorly, if you look at the attachment of the capsule, the epicondyles are left outside, and then you can see this capsule is lining all around at the margin of the olecranon fossa here. See, the point is, the things which are extracapsular here, obviously the capitulum, trochlea, all these fossas are intracapsular. But the medial epicondyle, that's a medial epicondyle. The lateral epicondyle, when you see from the anterior or from the posterior side, the epicondyles are left outside. Which also tells us that the muscles which are originating from medial epicondyle, the common flexor origin, the flexor muscle will come from here. And the common extensor, the extensor muscle will come from the lateral epicondyle. These muscles are completely extracapsular. So their origin is extracapsular, unlike the way we saw that long head of the biceps brachii, which is coming from the supraglenoid tubercle, is intracapsular. But the medial and lateral epicondyle will give origin to the muscle, and all the flexors of the forearm and extensors of the forearm all are extracapsular. They lie outside the capsule of the elbow joint. So that's the attachment of the capsule anteriorly and posteriorly on the humerus. When you look below on the bones below, we all know that radius, the head of the radius, is encircled by this ligament called as the annular ligament. So there we have this annular ligament here, and the capsule of the elbow joint, it merges with the annular ligament, and then it extends just below the coronoid process of the ulna. So again, you can see this is the coronoid process. If I mark it for you, this here is the coronoid process, which we said will be accommodated in the coronoid fossa. So this obviously is also inside the capsule only. Then only it is possible to go inside the coronoid fossa. So remember that the capsule attachment in the lower part is to the margin of the radial head, and that is, it is blending with the upper end of the annular ligament. This ligament which is encircling the head of the radius, that is the annular ligament, and that's how the capsule blends with it. Posteriorly, once again, there was an annular ligament here as well. So that's an annular ligament. So again, you will see that the capsule is merged with the annular ligament, and on the ulna, the capsule runs along the upper margin of the olecranon process, very much upper margin of the olecranon process. Olecranon process, unlike the coronoid process, is not inside the capsule. Well, the point being, this olecranon process will give insertion to the triceps muscle, and tricep again is an extra capsular muscle. So you will see it is attached to the upper border or the upper margin of the olecranon process. So that's how, let me just write that also, this is the olecranon process. So this here is the vicinity of the elbow joint seen from the anterior and the posterior aspect. Also understand one thing about the capsule of the elbow joint is the capsule is relatively thin from the posterior side. It is like thin from the anterior side also, but if you compare the anterior and posterior, it's more thin from the posterior side. And the aspiration that takes place in the distension of the elbow, which takes place because of the fluid get aspirated inside, that is usually seen toward the posterior aspect. So if the fluid has to be aspirated, that is done from the either side of the olecranon process from the posterior side. The elbow aspiration is done from the posterior side on either side of the olecranon process. The same story with the synovial lining. Obviously, synovial lining is present inside. It must be lining all above this, the radial fossa and the coronoid fossa and olecranon fossa also. But obviously, as we know that when we talk about the synovial lining, it is not present on the articular surface. So that must you should remember that the synovial lining is not present on the capitulum or trochlea or on the upper end of the radius or on the trochlear notch of the ulna, because those are the articular areas. Talking about the support, the ligaments of the elbow joint, the two main ligaments that we have in the elbow joint, we call them medial collateral or ulnar collateral ligament, and we got a radial collateral ligament. So let's draw them first, and then we will look into the image to compare it. So ligaments, first we have the ulnar and the radial. So let me start with the radial collateral ligament first. A radial collateral ligament, also called as a lateral collateral ligament of the elbow. If let us say you're looking at the humerus and the radius in the side view, if you're seeing it from the side, that's how it's going to look like. This is the humerus in the side view, and let us say this here is the medial epicondyle. Here is the radial head. And as we already said that the head of the radius is encircled by this ligament called as the annular ligament. The radial collateral ligament, it is having its apex attached to this epicondyle, that is the lateral epicondyle. The apex is attached to the lateral epicondyle, and then you will see this ligament spanning downward and merged with the upper border of the annular ligament, something like this. So this is what you call as the radial collateral ligament. That's the radial collateral ligament. Apex is to the lateral epicondyle, and then it spreads down and it is attached to the margin, upper margin of the annular ligament here. So that is providing the support to the elbow joint from the lateral side. The more important ligament on the elbow joint is the ulnar collateral ligament. So we have this ulnar collateral ligament, also called as a medial collateral ligament. And this ulnar collateral ligament is having three bands. There are three bands of the ulnar collateral ligament. Let's draw this as well. Now this time we'll be looking at the humerus from the medial side. So guys, if this is the medial end of the humerus, here is a medial epicondyle, And let's say this is the ulna with the trochlear notch and olecranon process. That is the so as I said, this epicondyle here is the medial epicondyle. And this ulnar collateral ligament is having 3 bands. So now what you will see that anterior band is spanning from this medial epicondyle to the medial surface of the coronoid process. Now this here is the coronoid process. We already saw the coronoid process. That's the coronoid process. So that's the anterior band. This is the anterior band of ulnar collateral ligament. The posterior band is stretching from the medial epicondyle to the medial surface of the olecranon process. So this here is the posterior band. That's the posterior band, and as you can see, it is stretching to this medial surface of olecranon process. So both anterior and posterior band, they are the stretching to the processes of the ulna, that is the coronoid process, and to the olecranon process. Obviously, from the medial side we are seeing, so it's a medial surface of coronoid process and olecranon process. And then we got an oblique band which is stretching between these, the lower attachment of both anterior and posterior band. So it is basically stretching from the medial surface of the olecranon process to the medial surface of coronoid process, and that is the oblique band. That is the oblique band. We do have some intermediate fibers in between also, but when we generally talk about the ulnar collateral ligament, we got 3 major bands. We have an anterior band, posterior band, which are coming from the humerus to the ulna, and then an oblique band is on the ulna itself from the medial surface of olecranon to the medial surface of coronoid process. And this ulnar collateral ligament is having one important relation, that ulnar nerve is related to it. So the ulnar nerve will be seen in relation to, we know that ulnar nerve passes behind the medial epicondyle. So when the ulnar nerve crosses behind the medial epicondyle, it will be related to the ulnar collateral ligament. So that's one important relation. So these are the 2 major ligaments of the elbow joint: the radial collateral ligament, which is attached to the annular ligament in the lower part from lateral epicondyle, and the ulnar collateral ligament, which starts from medial epicondyle and having 3 bands: anterior, posterior, and the oblique band. If I show these ligaments to you on a image, see, that's how they're going to look like. Here's a picture showing you all those ligaments, guys. This is the lateral view, this one here. So, and that is a medial view. So obviously you can see the radius can be seen here, and that's the annular ligament. That is the annular ligament. This here is the lateral epicondyle, and look at these fibers which are stretching downward and going toward the annular ligament. So that clearly is the radial collateral ligament. That's the radial collateral ligament. Whereas on the medial side, of course, that's the medial epicondyle. So you can see from the medial epicondyle, here's the anterior band. If I highlight that, that's an anterior band. This is the posterior band. And then below you can see the oblique band also. That here is the oblique band. The 3 bands of the ulnar collateral ligament. So that is the anterior band, posterior band, and oblique band of ulnar collateral ligament. So that is about, it's quite simple. It's about the ligamentous support of the elbow joint from the lateral side and from the medial side. Now from the ligament, let's come to the nerve supply. What is the nerve supplying the elbow joint? Well, all the major nerves are crossing the elbow joint, and all of them supplies it, starting from musculocutaneous, the median nerve, the ulnar nerve, as well as radial nerve. So when it comes to the innervation, the nerve supply to the elbow comes from musculocutaneous nerve, median nerve, ulnar nerve, as well as the radial nerve. All these nerves supplies the elbow joint. Blood supply, well, blood supply is simply by the anastomosis around elbow. The anastomosis around the elbow. Anastomosis around the elbow is by the branches of the brachial, radial, ulnar artery. They make an anastomosis around the elbow, in front and behind, medial and lateral epicondyle. So all those blood vessels are also contributing in the supply to the elbow joint. What about relations of the elbow joint, guys? When you talk about the relations, it's very, very simple to remember the relations, because see, when you say anterior relation of the elbow joint, all you have to think about is the cubital fossa. Think about the major structures of the cubital fossa. The four contents MBBS. M, median nerve, brachial artery, biceps tendon. So these are the major structure. I mean, we have a superficial branch of radial nerve also, but the main structures, if we talk about forming the anterior relation of elbow joint, are median nerve, brachial artery, biceps tendon, and one of the main muscles of the anterior compartment of arm and forming the floor of the cubital fossa, that was brachialis muscle. So if I just talk about the important anterior relation, it includes brachialis forming the floor of the cubital fossa, the median nerve, brachial artery, biceps tendon. As a matter of fact, anything that we saw in the cubital fossa can be written as an anterior relation. It could be the median cubital vein or the cutaneous nerve, which are passing and going below from the roof of the cubital fossa. But just looking at the important relations are, the muscle is brachialis, which is very much forming the floor of the cubital fossa and very close to the capsule of the this elbow joint, and then the major contents of the cubital fossa. Posterior relation is by the triceps muscle. The triceps muscle, obviously we know the tricep muscle inserts onto the olecranon process, so that is the one which is forming the posterior relation. Again, medial and lateral relations are also very, very easy to remember. Well, one of the important medial relation is the ulnar nerve. We just saw that ulnar nerve is related to the medial collateral ligament, so it is a medial relation of the elbow joint. Along with ulnar nerve, the common flexor origin will be there. Common flexor origin will be there. Whereas we talk about the lateral relation, one of the lateral relation of the elbow joint is one muscle, that is a supinator muscle. Supinator muscle, it winds around from the lateral side of the radius and then comes in front. So that's the supinator muscle is on the lateral side. Then the muscles like the brachioradialis muscle, the muscle which originates from lateral supracondylar ridge. So that muscle will be coming from the lateral side like brachioradialis. And again, the common extensor origin, giving origin to all the extensors, obviously coming from lateral epicondyle, is also the lateral relation here. So in lateral relation, I can mention the name of a supinator muscle, one, brachioradialis, and then common extensor, the common extensor origin. As we all know that lateral epicondyle is a common extensor origin, so that is also the lateral relation here. So these are important and very easy relation to remember for the elbow joint. Coming finally to the movements and muscles. Well, in the movements and the muscles, the only two movements, it's a hinge joint, so only two movements are there. One is flexion and then extension. So flexion at the elbow joint is done by the 3B here, that is a biceps, brachialis and brachioradialis. So the BBB, so we have a brachialis muscle, we got biceps brachii and even brachioradialis. Although brachioradialis is considered as a muscle of the posterior compartment of the forearm, the reason being the origin is not from the medial side, it is from the lateral side only, where we have the common extensor origin from the lateral side. So brachioradialis is also coming from there. And also it is supplied by the radial nerve, which is a nerve for the posterior compartment. Though when you see the brachioradialis muscle, you can see it from the front also, as it is forming the lateral boundary of the cubital fossa, but it is still considered as the muscle of the posterior compartment. Extension, well, there is no question about extension. The main muscle for the extension is the triceps brachii, and along with the triceps, anconeus, the small muscle which originates from the posterior surface of lateral epicondyle, that anconeus is also crossing the elbow joint, and it is an additional accessory, or you can say synergist, for the extension of the elbow along with triceps. Now, another important thing to be noticed when we saw the lower end of the coming to the the clinical part, if you look at the lower end of the humerus, in the trochlea, the medial flange of the trochlea is larger than the lateral flange. I mean, if here this is the lower end of the humerus, here is the capitulum, and if I draw the trochlea for you, the trochlea is something like this. It's medial epicondyle. So if I draw a horizontal line from the medial flange of the trochlea like this, from the lateral flange and from the medial flange, you will see that the medial flange of the trochlea is extending almost 6 millimeter below the lateral one. This is the lateral flange of the trochlea, this is the medial flange of the trochlea, and this extends almost 6 millimeter below the lateral one, which tells me that when the ulna will attach to it, when the ulna, the trochlear notch of the ulna will articulate with it, then ulna will not be articulating it in a way that it stays straight. The ulna has to be slightly angulated toward the lateral side. And that is what is forming the carrying angle here. The axis of the humerus is obviously straight like this, but because the ulna will be attached in this angle, so there will be an angle seen between the two, and this angle here is called as a carrying angle. That's a carrying angle. This carrying angle is like approximately 13 degrees, I would say. It's a 13-degree angle, the carrying angle. It's slightly more in case of female. So that is the angle which is basically present between the axis of the humerus and axis of the forearm bones. And when I say forearm bones, I'm mainly talking about the ulna, because that is the one which is forming the elbow joint. If the angle goes beyond 13 degree, then we call it a cubitus valgus deformity. It will lead to the deformity called as the cubitus valgus, which is having further outcome. We'll come to that. Now, carrying angle being, as I said, approximately it's 13 degree. It's slightly more in female. It could be like close to 15 degrees in female and around 10 to 12 degrees in male. This carrying angle disappears in the flexion. So when the elbow is flexed, so there is no carrying angle there, then you will see it is both forearm bones and the arm bones comes into the straight line. And also the carrying angle will disappear in the pronation. So once the forearm is pronated, then you will see the axis for the humerus and the radius and ulna will all come in a straight line only. There is a 180 degrees angle. It's basically there is no angulation between the humerus and the ulna. So carrying angle disappears in what? It disappears in the flexion of the elbow and also in the pronation. Now, as I said, if this carrying angle increases more than 15 degrees, it goes beyond 15 degrees, then we call it the cubitus valgus. The deformity is called as a cubitus valgus. And because of this cubitus valgus deformity, what happens is there is an undue stretch on the medial side, and that undue stretch on the medial side of the elbow will stretch the ulnar nerve as well. And this cubitus valgus will stretch ulnar nerve, and because of the ulnar nerve is stretched, so there will be a weakness of the intrinsic muscles of the hand. We know that it mainly supplies the intrinsic muscles of hand. So that will lead to the weakness of intrinsic hand muscles. This is what you call as the tardy ulnar nerve palsy. It's a tardy ulnar nerve palsy. Now, this tardy ulnar nerve palsy is basically when the ulnar nerve gets stretched. So it's like an indirect injury to the ulnar nerve. If there is a fracture of medial epicondyle or something, obviously there is a direct impact injury on the ulnar nerve. But if the angulation increases, for whatever reason, if there is a lateral epicondylar fracture, then again the angulation will increase to this side, and that will lead to the stretch to the ulnar nerve called as tardy ulnar nerve palsy. Or it could be for any reason, if there is a stretch to the medial side of the elbow and there's a stretch to the ulnar nerve leading to the weakness of the ulnar nerve, and there could be a numbness on the medial side of the palm and also on the dorsal aspect, medial 1.5, that is regarded as the tardy ulnar nerve palsy. Another condition, that is what you call as pulled elbow. What happens in pulled elbow is that if the head of the radius and the annular ligament, they are of not the same size, they are not of the corresponding size before the age of 3 or 4, So if we try to lift a kid folding his the hand or forearm, now that will lead to the head of the humerus to come out of the annular ligament, and that is what is called as a pulled elbow. So we will talk about the pulled elbow more in the radioulnar joint. So the annular ligament and the head of the radius, they are not corresponding, they are not very congruent, and that will lead to the pulled elbow if there is a pull which is given to the forearm. That's why we recommend not to lift the kids below the age of 5 holding their hand or their forearm, because that can lead to the head of the humerus coming out, head of the radius coming out of the annular ligament and causing this pulled elbow. So this is a little bit about the elbow joint. And for the PGME point, I would say the ligament is important here, especially the ulnar collateral ligament. They do ask question about the relation also, and also about the bands, the anterior, posterior, and the 3 bands of the ulnar collateral ligament.